about the importance of vitamin D, which most probably your levels will be higher what you require. So, thinking about that, put the breast milk aside. What I'm talking about is when you have not got breast milk available, what to do next. Now, when I saw yesterday the hands being put up, I realized not all of you are allergists. So forgive me for putting you on the same level. I just wanted to make sure that those of you who are oncologists who are not, or neurologists who are not working in this area, I need to make sure that you know what a hypoallergenic formula is. There are two definitions, and the first definition is an in vitro definition, which says that you have to have less than 1% immunoreactive protein in total. But as I said, this is an in vitro assessment, and the reality is the Dalton size does not have a reflection. We don't know if it says, for example, 90% is below 1.5 kilodaltons. There is absolutely no evidence of that having bearing of a clinical reactivity. So most of your committees, the AAP, ESPGAN, and IACI, all of them have favored now the second definition, which really is that a product is labeled as hypoallergenic should be tolerated by 90% of children who have got a proven calcium protein allergy with a 95% confidence interval. So you'll see all the new formulas now will have to abide by that criteria. There is a secondary criteria which is often forgotten, and that is really also that after you've done your double-blind challenge, to account for the non-IgE mediated delayed reaction, that you actually continue with that trial formula for a couple of days after. So, to put it to you graphically, what we have in terms of suitable hypoallergenic formulas, these are the formulas that we know: intact whole protein. Then we've got your partially hydrolyzed formulas. Partially hydrolyzed formulas are only for allergen prevention, not for allergy treatment, and really those that are suitable for the management of calcium protein allergy are really your extensively hydrolyzed formula, the amino acid formula. There is intact protein, non-calcium-based protein. I don't spend a huge amount of time on that. That's, for example, your oat, your rice, which we'll touch on, and a little bit of soya, which we'll talk about a little bit about guidelines as well. So now that you're all more or less, I hope, on the same page in terms of what is hypoallergenic, I'm going to give you a case, and I hope you all had breakfast, and I'm not put up by the photo, but the reality is my email inbox is full of parents sending me photos of stools. And this is a child that's a 4-month-old boy. He had 15 medical opinions. It often happens that you have that, 9 GPs, 4 pediatricians, and was referred to a pediatric gastroenterologist who then identified and said, I think this is a non-IgE mediated allergy. This child's symptoms were vomiting effortlessly with back arching, straining excessively, mucus in the stool, and you can see that very clearly here, but no blood. Has got eczema, and the eczema is poorly controlled, and we often see it's around 40% of our population that have gut symptoms also have eczema. And the mother says this child is really feeding badly, does not want to drink the formula, and I'm sure you can identify with that. In fact, in the UK NICE guidelines for allergy, the feed refusal, in addition to some of the other symptoms, is part of the symptoms for identifying non-IgE mediated allergies. This child has had multiple feed changes, which I'm sure you see the same. They go from the comfort milks, the lactose-free milks, and by the time you get them, they had 4 or 5 formulas. But most worrying, this child has dropped both in weight and in length. So 2 centiles in weight was dropped, and 1 centile in length. So for us, if you drop 2 centiles in weight, it's 1 centile is 0.67 standard deviation. So you've dropped by 1.2, 1.3 standard deviation. So that's for us faltering growth. So Dr. Fox is going to talk after me. He'll talk a little bit more, but what we're really looking at in the nomenclature is a non-IgE mediated allergy, so delayed type allergy, which you have all of these categorized under the proctocolitis, the enteropathies, the FIs. So you all have your colors. You were not expecting to come this morning and not do anything. So the question that I've got for you is, what hypoallergenic formula would you suggest for this child? You've got the child in front of you. For those of you who've got all green, I really already see a red up, a yellow, extended extensively hydrolyzed formula, and I know many of you don't have extensively hydrolyzed formula, just have amino acid, and the last one is red amino acid. See some reds, which are countries, and a green. Okay, so actually, about 50-50 spread, and I've got some greens here as well. So let's think, first of all, where to start off with this chart. So, it's always quite good to look at guidelines, and forgive me if I've not got your local guidelines, because I'm sure all of your countries have got local guidelines. What I've just got is some of the British guidelines, the international guidelines, the ESPEN guidelines, and you'll see that there are two categories in particular for anaphylaxis and for eosinophilic esophagitis, including the ESPEN guidelines. They're very clear. Amino acid formula would be your first line, but for all the others, there is a little bit of discrepancy what each guideline says, and I think also it's cost-driven and it's product-driven what you have in your country. So let's think about what we're going to do in this chart. So for those of you who've got amino acid and those who've got extensively hydrolyzed formula, the reality is in IgE-mediated allergy, and this chart does not have an IgE-mediated allergy, we would say around 10% continue to react to an extensively hydrolyzed formula. However, non-IgE mediated allergy, so the type of gut allergies that we have, if we look at Latcham's data, around 30% will continue, so you have a higher percentage that fail on extensively hydrolyzed formula. An easy point for you to start is always what happened with breast milk. My child was absolutely fine on breast milk. When I gave the formula, my child started to have mucus in the stool. That's a very important point. Why? Because if you look at the beta-lactoglobulin content of an extensively hydrolyzed formula, remember it's not, an extensively hydrolyzed formula still has some short peptides. The beta-lactoglobulin level, which is a household-specific protein that circulates through breast milk, is very similar to what you have in an extensively hydrolyzed formula. So a child that already had these severe symptoms whilst on breast milk, you already know this is most probably a patient that will need to go to an amino acid formula. Now, this is just some data to give you the detectable beta-lactoglobulin level. The other aspect when you make a choice about amino acid formula and extensively hydrolyzed formula is the aspect of growth. I've told you in this case, already 2 centile drops in weight, and more concerningly, already centile drop in height. Consistently, and I'm just mentioning 2 studies which are the more important studies from Isolari, Bordo-Nigerman in Germany, they have found that longitudinal growth, height growth, so weight gain was very similar, but consistently height catch-up was higher. We could hypothesize about that. I personally think it's related to the inflammation of the gut, and you most probably by giving an amino acid formula tailor that, but the reality is we don't know. But for me as a dietitian, if I've got a child that's not growing and has got the severity of symptoms where they've already started reacting on breast milk, for me it's no question I would put them on an amino acid formula. So this is a very, very easy chart. It's published, you can get it on PubMed, which I've got, which tells you exactly what I've now said. Breastfed child, you start first on an elimination diet, and if they continue to react, then based on the beta-lactoglobulin later, you haven't got a choice, you have to go to amino acid. And the other ones that start on a formula and only react, you can go on extensively hydrolyzed. However, through David Hill's data, we have a subgroup which says those with severe non-resolving atopic dermatitis, those that have got anaphylaxis, those that have got faltering growth together with these should be on an amino acid formula. So there's your answer. This case I would have put on an amino acid formula. So the next question is the mother says to you, okay, that's great. So the mucus and stools have resolved. Well, if I start on the right hypoallergenic formula, will the fact that my child seals their mouth, turns their head away, will the right formula improve the feeding difficulties? So green is for yes, yellow maybe, I'm not sure, and red is, I'm definitely, no, I don't think that's the case. I've got lots of yellows coming up, not sure. Greens, about a 50-50 spread between green and, okay, so, in the non-IgE mediated population, which this child is, in our prospective data, about 64% of children have got feeding difficulties when they present with this allergy. In our retrospective data, we have two cohorts, about 40%. And if you look at our data, you can see clear associations: vomiting, weight loss, constipation, and rectal bleeding. All of those were strongly associated with the development of feeding difficulties. What we have found is when you actually improve their symptoms, so instead of making an association with the formula, it's all about symptom improvement. So by improving their pain and discomfort, because what happens, your afferent pain pathways are affected through continuous painful stimuli, and therefore your sensory perception is affected. So what do the children do? They gag, they have texture issues, they don't like color. So once you improve that, it doesn't happen like that, but we see that their feeding difficulties improve, and also the association with food. So what I normally tell parents is that you'll see an improvement, but depending on how old the child is, if the child is 10 months and has had these symptoms, the association, the negative association with the behavior related will take some time to resolve. So your case continues. You start off with amino acid formula, and lo and behold, the symptoms improve, the weight started to increase, which is really what you want to see. Mom wants your advice now on complementary food introductions, and the question is now how to proceed. You have a 6-month-old, what you've shown is symptom improvement on an amino acid formula. The question that I've got for you now is, what are you going to say to the mother? Okay, you have to wean just cow's milk free, so you can introduce everything else but cow's milk. You have to go cow's milk and soya elimination, or the red one. No, I'm going to ask you to take everything out. Milk, egg, soy, and wheat elimination. I've got reds, quite a couple of reds, everything out when you start off. Actually, 90% reds, and then I've got yellow with my nutrologists in front, very high. So let's think about it. And, you know, in theory, there are two approaches. We call it the top-down and the bottom-up approach. So the bottom-up approach means we take just milk and soy out, and we actually introduce everything and work our way up. The top-down approach is what some of you, or the majority of you, said, I'll take everything out and then, because that's the safest. We actually have data to reflect exactly what these two approaches. So now, retrospective cohort that's been published, which is from 2002 to 2009, we showed that the most common method of elimination was milk, egg, wheat, and soy. So when we come and they asked us, what do we do? We say, oh my goodness, take everything out. But since then, we've learned, and this is our prospective data, which is actually just been published end of last year, and these are food challenged, and I just want to be open about it, home challenged, okay, not double-blind with these delayed reaction. Cow's milk and soya is most probably your most common one. And then it's only followed by cow's milk, egg, soy, and wheat. So in this patient, most probably we would have just taken cow's milk and soya, the soya based on the fact that in non-IgE mediated you have concomitant about 50%, of concomitant soya allergy. And we would actively introduce, I always say my deadline for introductions of wheat and egg is by 8 months of age, and that includes peanuts and fish. I introduce all of it and I don't delay it. I just want to say, make sure I have allergists on board like Dr. Fox. Before we give any of this, we always rule off IgE, so we do sequence tests, but Dr. Fox will talk a little bit more about that in terms of the diagnosis. So I don't think that those of you that said start everything out would be wrong initially, but you need to actively introduce those that you don't know, because remember, you have got no idea what will happen with egg, what will happen with wheat, and delaying it unnecessarily is not only a nutritional risk, but also a problem when it comes to feeling and taste selection. Now, the question also a lot of people have asked me is, if I eliminate 2 foods versus 3 foods, does it have an impact on growth? This is UK data, but Flammarion from France also has very similar data that showed that the more foods you excluded, just randomly excluded, the lower the weight for age Z score is. So just to kind of go and say, I'm taking the food out does not make sense. So you need to really think about it when we are thinking about an elimination diet. I will talk a little bit more about stunting, but just to say that we have a high level of short children and food allergy, and we are starting to see children that are overweight or obese as well. So this lovely child is continuing. So you've said introduction of complementary foods occurs. Initially just milk and soy free, so wheat, egg, fish and nuts were introduced without any difficulties. And we have a system where I really help the parents to introduce this and have protocols for egg and for meat, which they can do at home. So what you've noticed with your next clinic appointment is that weight gain is really improved. You've had a nice catch-up, and they're back on the birth centile. And at 10 months you notice that although his height growth has improved slightly, there is no significant catch-up, which is a big worry in our nutritional screening that youths are happy about weight. The phenomenon that high plasma catch-up has been already documented by Eric Carcinari in the end of the 90s. This is a chemical protein allergic phenomenon. If you think this is your healthy children, this is the early onset, so those patients that had early onset protein allergy, late onset. This is your length standard deviation, or length score. And you can see they've all been put on an elimination diet, cows milk protein free, appropriate, and although they are free from cows milk, you cannot see the height growth catching up. In the late onset, you can see slight catch up. So the question we have to ask ourselves really is what's happening. In our cohort, and this is data we've literally just submitted yesterday, is the impact of growth before and after. These are all dietitian-seen patients. And I want to highlight what happens. So this is weight for age before they're on the elimination, so -0.203. And that's after they've been on the elimination diet, so we've come close to 0, so significant difference. And the same for weight for height, but we've not shown significant improvement in height growth. They've all been seen by a dietitian. And if we look at our prevalence of stunting, we'll see it's around between 8 and 10% in our population. One aspect I want to highlight today is we all know that the elimination diet, this aspect that has a nutritional impact, we know that if you take food out, the potential of it impacting on your growth is huge. What has not been studied is really what about the inflammatory response, your asthma, your allergic rhinitis, your eczema, that clinical level of inflammation that's there. How is that affecting height growth? Because those that are gastroenterologists that work here with ulcerative colitis and Crohn's disease know this children are short. And if you look at the cytokines that overlap with an allergic response are very similar to those that are blamed for short stature. The other aspect is we don't ever look at what a chronic low-grade inflammation has on appetite. If you've got a malnourished child, I come originally from South Africa, if we have a malnourished child, we say the inflammatory response itself reduces appetite. So think about those patients who may have a cohort and in spite of the best efforts nutritionally, they may still be having some low-grade inflammation. That's where I always go back to the doctor saying, is the eczema treated appropriately? Is the asthma treated appropriately? Because that is so important. So your question now is, how are you going to address this nutritionally? And all of you should now know from yesterday's session, how are you going to address this nutritionally? Because I've given you some insight yesterday in terms of protein and energy. So would you add carbohydrates and fats to amino acid formulas? Would you concentrate the amino acid formula and show more protein and energy complementary feeds? Because remember, I don't have a 1 kilocalories per meal amino acid feed below the age of 1, unless I work some miracle with it. So what would you do? Green, add carbohydrates or fat to the AF, yellow, concentrate the AF, red, ensure more protein and energy in the complementary form. Lots of greens, some reds, some not wanting to say anything, ensure more protein. So I've got actually, I think, more to work on the diet. So let's have a look. I'm not going to spend a huge amount of, sorry about, for some reason this is data that has not come up properly, but unfortunately I wanted you to show the statistical impact. We have just recently looked at a cohort. We looked at the impact of different nutritional factors. And what we found statistical through very complex regression analysis, that hypoallergenic formulas improve weight gain, triceps skin folds, MESEAA, so mid-upper arm circumference. Vitamin and mineral supplementation has an impact on weight for height. And remember what Josephine Garvey said yesterday, your type 1 and type 2 nutrients, so important. We've shown it actually in our allergic patients. And achieving energy and protein intake, and our mean intake was around 14%, which was positively associated with protein. Impacts on head growth, weight for height, and catch-up. And that's an extremely important point. So that's why we're looking at what can we do. You've seen a similar slide yesterday. You need to think, if you add in carbohydrates and fat, similar to an amino acid formula, you're going to disturb the protein-energy ratio. What is going to happen is that you see a weight going up, so scales are going up, but the catch-up growth that you have is not the catch-up growth that you want, which means optimal lean muscle mass. So the other problem that you've got is the increased osmolality and the accuracy of mixing it at home. We don't have ready-to-feed formulas when it comes to an amino acid formula. And we all know, been at home and go, I'll tap it against the tin, I'll scrape it off, and now you're adding an extra step. It's very inaccurate. And remember, if you're making it more concentrated, you are also changing the taste. And that's very important to think, what is the taste like? We actually did a study looking at exactly what is going to happen with the protein energy content. And just to circle you, if I added into MESEAA and supplemented it up to 100 kilocalories per 100 meals, I would actually have 7.6% protein. That's too little to have proper catch-up growth. If I were to concentrate it up, then you'll have, and I've got just an extensively hydrolyzed formula to show, we'll go up to 446 milliosmoles. If you've got a refluxer, what will happen with 446 milliosmoles, you'll have the vomiting, so you'll think you do something good. In the same publication, though, instead of me giving you problems, please spend some time. I have done calculations in terms of what you can do and what is safe to do within feeds to give you still the optimal range. So in this case, what I've done is I worked on a complementary food, because when we looked at dietary intake, in the UK, what we find is that yogurts and cheeses are a big part of the diet. And by not having yogurts and cheeses, they have these little fruit pots, I don't know, or they squeeze them out. So we've seen a shift into higher carbohydrate, refined foods, and a lower protein intake in many of our population. So I pushed the protein content in this child. I said to the mother, you have to keep to at least 600 milliliters of the amino acid formulas. We provide recipes, and I ask them to cook with the formula as well, and we have wonderful support there with dietitians that work together with the companies to develop recipes, and we could see that slowly hygiene was improving. At that stage, we challenged with cow's milk and soya, and that's so important to challenge. We found with both of them this child was still reactive. At 1 year of age, changed the amino acid formula to an over-the-counter milk, whatever you have available in your country. Oat milk, rice milk, coconut milk. Yes, no, or I give a combination. No. No, no, no. And I've got some combination. Okay, so I think in this one, most probably the growth would for me be an overriding concern. This is a publication we did last year, and it was really to give you an indication of where we are. The calorie content is very similar to skim milk, so not full cream milk. But if you look at the protein content, it's extremely low. And we would, if the child has not had maximum catch-up growth, we would certainly not, below the age of 2, switch any formulas to from a hypoallergenic formula. If the child was growing really well and did not have multiple food allergies, I may consider it, okay? For us, there's a huge amount of cost pressure, but for me, the nutritional intake and what the balance of the diet is very important. I do allow them, for example, for some of the cooking, if they're growing well, to use some of these coconut milks or other palatable milks. Now, the next question is about What about hypoallergenic formula and micronutrient content? Here I've shown you the protein content, but what is the impact on vitamins and minerals? And what I want you to do is just focus on this column. What we did, we looked at the cohort that had over-the-counter formulas, so no formulas, and we had patients who were on hypoallergenic formulas, and we looked at the vitamin and mineral intake and compared it. And you will see almost all of our levels, except for riboflavin, the intake of vitamins was significantly lower if you were, and that's total diet. I'm not talking about, I'm talking about the diet, hypoallergenic formula with milk, with food, and over-the-counter milk with food. So, and we found that if you had them on a supplement and no supplement, you'd be in real trouble. And we most probably are the first group to have shown what most of the guidelines have said, which is that you should continue up to the age of 2, because if below 2 years of age you are not on a hypoallergenic formula, you're still allergic, your intake of micronutrients is very low. So I'm coming to the conclusion really that I hope I've managed to show that nutritional management of cow's milk protein allergy relies on choosing the correct hypoallergenic formula. The correct hypoallergenic formula has far-reaching impact not only on your symptom resolution or feeding difficulties, and in particular height catch-up growth. And remember what you've heard yesterday, the long-term effect of your height is huge. The other important factor I hope I've shown is the importance that you need to not delay food and re-challenge constantly during the process. Stunting is common in this population, and you need to manage this appropriately from a nutritional perspective, but you have to consider other possibilities. Hypoallergenic formulas impact on growth and protein impacts on growth. You have that magic number by both myself and Dietary mentioned of maximum around 15%. We've more or less substantiated that, saying that the positive association we found at 13.8 to around 14%. Feeding difficulties are very common, require input, and I think do not just think about type 1 or type 2 nutrients. Think about your vitamins and minerals that aid your growth, so that you don't just focus on energy and protein. And I'm going to end with that and say to you, please feel free to email me. I'm sorry that I have to rush off like this, but I will make sure that Julian has my presentation, and if there are any outstanding questions, we're always happy to share wherever data has been published, to share whatever we can. Thank you very much.